Thank you very much, Adrian. Good afternoon, everybody. I want to start by comparing two industries. The first one, established in 1890, decentralized, works in a challenging environment. The workforce isn't a professional one, it's poorly educated, but a very big scale operation, 260,000 transactions a day, 6 days a week, 52 weeks a year. Until recently, at least, no information technology support. Can you guess what the industry was? Well, it was the Dabbawalas of Mumbai. Now, they are people who deliver, the Indian people do particularly go for sandwiches in the workplace. They like to have their own food delivered, so they cook it at home and they put it in a little container, and then it's delivered to their office, and it's then taken home at the end of the day to be refilled the next day. And all this is done by a system of men on bicycles, mainly men, and trains. So all of those transactions, something like 175,000 every day, are carried out. How often does it go wrong? Well, the error rate is comparable to the best performing industries in the world. And this has been featured in many Time magazine and many articles. You can read about it in more depth. Let's look at another industry. Many similarities, unpredictable, challenging environment, but this time a highly educated workforce, similar level of transactions with plenty of IT backup. Healthcare, that's how often things go wrong. On average, 1 in 10 hospital admissions result in some form of error. Quite a difference, isn't it? Now, you could say, well, that's because healthcare is very complicated. It's much more complicated than delivering tiffin to people's offices. But nevertheless, there's something in the scale of the difference between those two industries. And other industries do tend to think about harm a lot. This, I happened to walk past the other day near my office in St Mary's Hospital in Paddington, and this is some work being done on Paddington Station, and there is the sign that the developers have put up. Not we try to reduce accidents, not that we are careful, not that we're a safe industry, but the bold claim, aspirational claim, that all harm is preventable. So that is, if you like, the common garden field of the construction industry. That was a casual observation. This is a causal observation. And this is in the public domain. It's from a very nice system that the Royal College of Surgeons run. They don't get many reports compared to the system that I'll be describing in a minute in the NHS. But certainly, they are quite open about trying to learn from them. And I'll read through this report very, very quickly. This is by a surgeon reporting into the surgical reporting system that they run. He was undertaking an outpatient procedure, a standard procedure for injecting somebody with hemorrhoids, piles, and it's a standard procedure to thrombose the piles and shrink them. And he was using a solution of phenol, 5%, to inject at 4 sites, and he was passed the phenol already prepared in a syringe, ready for injection. He confesses that he didn't check the phenol composition, but it was later found, following what happened, to be an 80% solution, not a 5% solution. The patient, it was intended, such a solution, for thrombosing varicose veins. And the patient ended up with a colostomy because the section of lower intestine was necrosed by the strong phenol solution. Now, that is a rare event, but nevertheless, when the public see it, they think, how can this even happen at all? And tragically, the surgeon, there's a longer account of this report in the journal, of the College of Surgeons, he said that this was probably the only time in 30 years that he hadn't double-checked everything. But because he was working with a nurse that he'd worked with for 20 or 25 years, he didn't on this occasion. He was in a rush and he didn't check it. So there is a rare but catastrophic error. Nobody was killed, and we tend not to look at the incidents where people don't die, but we see there a life-changing event due to a simple twist of fate. And those sorts of errors, although they aren't common, they occur sometimes in clusters. And this was the series of events in one of our premier hospital, Adam Brooks Hospital in Cambridge. And in only 6 weeks, there was a series of events which involved surgical items left inside 2 patients, surgeons operating on the wrong side of a person's body, and in a 4th error, a wrong implant was fitted during an operation. Clustered in there are 59 specialties of medicine. This is just one specialty over a 6-week period. It doesn't suggest that it happens every 6 weeks or everywhere, but it is certainly a cause for concern when an error of that kind can be replicated in such a short space of time. 3,000 miles away, the Rhode Island Hospital is in America, and it's affiliated to an Ivy League university, the Brown University, and in only one of the specialties of medicine, this time neurosurgery, 3 serious errors occurred in a 1-year period. One operation went awry after an experienced brain surgeon insisted to a nurse that the side of the head to operate on was the one he was convinced about, but he got it wrong. Another time, a doctor in training cut into the wrong side of a patient's head after skipping the preoperative checklist. In a 3rd case, the chief resident started the brain surgery in the wrong place, and the nurse didn't feel able to challenge him. One of our prominent patient safety or safety experts, Professor James Reason, now emeritus professor in the University of Manchester, said that if the same error happens to different people in different places at different times, then we have an error trap. There are common features, and those common features need to be explored and dealt with. One of the problems of healthcare is that these problems, although evident, have not necessarily been resolved, and they tend to occur even today in different parts of the world. So we don't yet have a solution to some of these events. Now let me take you to another industry, and this time rather than the airline industry, which is very frequently cited, I've chosen a rail disaster. Now this was, these sorts of trains we don't particularly have in the UK, but in North America, Canada and the US, they have these really big long freight trains that go right across North America. They travel, because of the wide gauge railways, they travel relatively slowly, and they are often parked up overnight. And this was a disaster that happened in Quebec province in Canada. It involved a train pulling some 70 or so coaches, each of them filled with crude petroleum. And what happened was that the train was being parked for its overnight stop, its overnight rest. And there is a procedure governing this, in that the train is supposed to be parked with a particular configuration of brakes tested to hold the train in place. And there are a mixture of brakes, mechanical brakes and air brakes. So what happened when the train was parked up overnight for its rest was that the engineer checked the train was well held in its place on the rails, but he didn't check. The procedure was meant to be the train's meant to be held by the mechanical brakes alone. So you have to decide how many brakes to put on in order to hold it in position. Because the engine was running when he did his check, the air brakes were involved as well. So the train held firm and was tested, but it was being held by mechanical brakes and air brakes. He went home, everybody went home went to the place they were staying for the night, which was standard practice, and left the train. Then a call came from a member of the public that the train was on fire, or the engine of the train was on fire. And the fire brigade was called out. They put the fire out. They rang the railway company, but the railway company didn't think they would send out the chief superintendent. Instead, they sent a duty person who wasn't particularly familiar with the procedures in such a situation for parking a train. And so the advice was given that the engine could be switched off because of the fire, even though the fire was put out. Within a few hours, the train started to roll downhill. It reached a speed of over 100 miles an hour and came off the rails, spilling 6 million litres of crude petroleum in a situation where there was still a spark from the train coming off the rails, and it exploded into a fireball and went in to a small town and razed part of it to the ground. And obviously there was an inquiry, and some of the findings are set out on this picture here. But basically what happened was that when the engine was switched off, the air went out of the air brakes. So the train was being held by the mechanical brakes alone, and it wasn't enough to hold the train in place, and it started to roll. So the elements of this which are important in making the comparison are firstly that most accidents, and when I talk about things in healthcare, let's use the term accident as well. Most accidents involve multiple factors, some procedural violations, some behavioral or so-called human factors, and some failures on a mechanical level or with equipment or something of that sort. And they're usually a mixture coming together to create a unique set of circumstances which appear unique but can be repeated in other situations. The other interesting thing about this situation is the rigor with which investigations are carried out in other sectors when there are serious accidents. In healthcare, they tend to be done by Royal College investigation committees, things like that, which are, though very thorough and conscientious, don't look at the problem from a safety perspective, or at least haven't until now. And the third thing, which is very, very interesting and isn't really talked about very much, is that in many major accidents, you can look back at the things involved in the accident and find something similar happened before, or that the true cause of it was right upstream. And I'm going to give you an example in healthcare in a few minutes, which I've found quite shocking. I think it may shock you as well, about an upstream factor that we would never have thought of. But in this particular case, a year before this catastrophe, the engine had been repaired, but because of time pressures to get the engine back in service, or possibly because of cost, an engine oil seal that was leaking was replaced with a seal that was not adequate to seal it properly, that was made of inferior material. So essentially, the seeds of destruction were sown a year earlier. The use of that seal made it inevitable that there would probably be a fire, and then the fire was what triggered the other events, although all the other factors were clearly coming together. So that is why we often make comparisons with other industries, because A, they're more thorough in their investigation, B, they're more revealing in showing the panoply of things which can occur in an accident, and in healthcare we don't usually look at things in that comprehensive way. C, there's often something upstream that you wouldn't have thought about, and D, they learn better, and when things go wrong, they get safer the next time. Certainly the airline industry does, which has successively become safer year on year on year on year. Healthcare stays pretty static. It's unsafe and it doesn't get much safer, except in particular limited circumstances. So that's a comparison. Now let's move to healthcare. This is an example that I have used over and over in over the years. It's dear to my heart because it is one of the most catastrophic events that can occur in healthcare, but it's very rare and very tragic, but it shows all the ingredients of an accident, and therefore, as an example, as a benchmark for exploring things that go wrong, it is a classic accident. And I included it in my report for the government called An Organisation with a Memory. The boy was a 16-year-old boy in Nottingham. His name was Wayne Jowett. He was in remission for acute leukemia. He was being treated with 2 drugs, one injected into a vein, one injected into his spinal fluid, or intrathecally. And each drug had to be used in the correct route of administration. The 2 drugs looked very similar. At the time, they were packaged in a similar way, same amount of clear fluid. There was a different color coding, but it varied from hospital to hospital. And essentially what happened was that Wayne came up to the hospital. He'd missed some of his treatments. Like any teenager, he wasn't always cooperative. His grandmother had influence with him, persuaded him to come up, and the hospital wanted to fit him in out of sequence because they knew how important it was that he should get his treatment. But 2 junior doctors gave the procedure, one giving the drug and one giving assisting, and the one who volunteered to help was actually on an induction period and wasn't meant to do anything clinically, but as no one else was around, in his eagerness to help the patient, he stepped forward. And what happened was that the drug vincristine that was meant for his vein got injected into his spine, and he was paralyzed and died. A very traumatic set of circumstances. I met his parents. 5 years later, no one had really talked to them about this. They were deeply, deeply, deeply traumatized by not just the event, but the way they were handled in the aftermath of it. Because it's such a good example for exposing the accident in healthcare, we've created a teaching video which has been used here in Cardiff. There's even the warning on the syringe, vincristine, not for intrathecal use. But let me show you this dramatized version of a similar incident. Now, we had this working earlier. Yeah, here we go.
Is that okay?
Okay, fine. Vincristine, 2 milligrams in 2 mils.
Right. Okay, that's it. Got a plaster? Excellent. Okay. Brilliant.
Sorry to hold you up. You can't have finished already.
Yeah, we have, yeah.
I've got the methotrexate. So what have you given her? Oh my God.
Can someone call Dr. Monroe, please?
Well, even having seen that hundreds of times, it still chills me to the marrow to see the circumstances of that. Conscientious staff doing their best. The patient, if it was a real patient, would have been paralyzed in intensive care for probably 4 or 5 days with the neurotoxic effects of the drug. She would have known she was going to die, and then she would have died. And this is not a simulation of the real case of Wayne Jowett, but in the case of Wayne Jowett, one doctor ended up in jail on a manslaughter conviction. Others who've been involved in similar incidents, and there've been, at the time of this, there'd been about 50 in the world, of which the majority reported were from the UK, but the treatment of the doctors concerned were ranged between quiet counselling and re-education and prosecution. And so sometimes people talk about the second victim, and that's, I think, very relevant here, although, of course, all sympathy and must go to the patient and the relatives. But in this particular case, instead of asking a Royal College to investigate, I asked an accident investigator from outside the health field to look at the case. And he did things which are not usually done in health investigations. He did a reconstruction of the incident. And he found 40 failures along the chain of events, including, as you saw, the confusion over the labelling of the medicine, the fact that they were brought to the clinical area in the same plastic bag and stored together where they should have been separated, the fact that at the time there was no proper protocol in place, that a senior doctor was supposed to supervise and a message was sent to his office, but he didn't get the message, and the junior doctors were inexperienced, and the list went on. So rather like the rail disaster, were a combination of events coming together, and probably one of the most dangerous is somebody being taken out of sequence in a high-risk procedure that you don't want to have that happen unless you can avoid it. You want everything to be planned and expected. But the report, if you ever wanted to read it, by Professor Brian Toft, is in the public domain, and it's a masterpiece of explanation of a health accident of this kind. And I said that up until that time there were 50 or so such incidents reported in the world's journals, probably more that weren't reported in journals. And then a couple of years ago, the figure tripled. There were an extra 150 cases reported over a couple of months period. Can anybody think why that would have happened? Well, what happened was, I mentioned the upstream surprise. What happened was that a Chinese pharmaceutical plant was manufacturing the two drugs in the same plant, the vincristine and the methotrexate. The methotrexate being the drug that should legitimately be given intrathecally. But it became contaminated by traces of vincristine because they were being manufactured in the same plant. And it was a Chinese drug manufacturing company that exported all over the world, but fortunately, not this particular product. It was restricted to China. So out of the blue, the Chinese started to see cases of paralysis occurring in children and teenagers across the country. And it took some time to understand what had happened. But it was a national catastrophe. It could have been a global catastrophe. And it happened because the part of the chain of risk and causation was not thought about. Rather like the engine seal that I talked about in the other example. Another brief example I mentioned earlier that some incidents we don't seem to be able to do anything about. This is a gentleman who was much loved. He was a celebrated musician who played on the soundtracks of Star Wars and Harry Potter. He was admitted to hospital as part of his care. He needed a nasogastric tube fitted, which is a tube that's put into the stomach to feed somebody who can't take fluid in the normal way. And there is a checking system to see whether it's in the stomach rather than the lungs. And in this man's case, he was fed, the tube was in his lungs and the fluid was pumped into it, and he basically drowned in the fluid and died. There was an inquest, and the coroner's analysis is, as always, very, very thorough. And what happened, and I'll just quote from this at the inquest, the two people involved were a junior doctor and a junior nurse. And the nurse reported to the doctor that she was concerned that she couldn't remove fluid through the tube. An X-ray was performed, and the doctor, the junior doctor, said, "The tube's fine, go ahead." And he came back on his rounds a couple of hours later to find that the nurse hadn't fed the patient because she still had doubts, and he was absolutely furious. And I quote what he said to her when she said she was unhappy about the situation. The doctor said to the nurse, "You don't have a brain to remember that I told you to start the feed. The tube is in the right position." It wasn't in the right position, and the patient died. And you may be familiar with this metaphor of the Swiss cheese. This was James Reason's concept that I identified earlier. It's a standard used in safety for explaining and educating and thinking about unsafe situations. Basically, Reason said that the slices in the Swiss cheese have holes in them. If there are too many holes and they align, faults in the system, if you like, then you can get an accident. And what should be in place in every system, whether it's rail or air or nuclear power or a hospital or primary care service, is there should be defences in there. And those defences may be many, many dozen things. But for example, procedural guidelines, the professionalism of the staff, a team culture, fully trained staff, good communication. Now, if you're a patient going into hospital tomorrow, and these things are eroded in a major way, these defences, then you should be very, very scared, because your chances of meeting harm would be quite high. And in Mr. Murphy's case, there were gaps right along the board. The procedural guidance wasn't followed. There was an arrogant and inappropriate attitude. Obviously, these things happen, but the individual doctor's behaviour clearly was a core element of the catastrophe. There was a hierarchical attitude. The nurse didn't feel able to stop the production line, which in Toyota terms, anybody can do. They can stop the production line. And some of the air crashes that have occurred in the past, very celebrated crashes where at one time a pilot flying into a cliff, and because the co-pilot felt the senior pilot was of such a stature, he didn't feel able to challenge him. And all of that experience in other industries has led to hierarchical attitudes being regarded as one of the most unsafe things that can happen. I was giving a talk, a visit for the WHO some years ago in Cameroon, and I talked to them about hierarchical attitudes and group of doctors and nurses. And I said to the nurses, if you saw a surgeon going to examine a wound without wearing gloves or gown or cleaning his hands, would you feel able to stop him? And it was about 5 minutes before the laughter died down, because they considered it totally absurd that a doctor could be challenged. Again, hierarchical attitudes. Go into an organisation with that and you're in danger. And then clearly the staff had insufficient experience. So these are just examples of some of the things that went wrong. But looking at it in a Swiss cheese way helps you to understand the vulnerabilities in an organisation or in a system of care or in any other field which lead to the risks of an error having a high impact being much, much higher. Nasogastric tube incidents reported as never events to the NHS in England. The old National Patient Safety Agency put out 4 or 5 alerts. Didn't make much difference. Still happening. It should be an error that we could completely eradicate. How would you feel if your relative went into hospital tomorrow and then the day after you would telephone to be told that they'd been killed due to a rare circumstance where fluid had been put into their lungs? It would be unacceptable, totally unacceptable to you, but we expect the public to tolerate this sort of situation where we are unable to eliminate a preventable error because of lack of ingenuity or lack of commitment or lack of passion for safety. I'm being provocative, I know, but somebody needs to be provocative about these things. A couple of reports which helped to set the agenda, the Institute of Medicine report in the US and my report, An Organisation with Memory. If you wanted to look into the subject further, they're a very good starting point to look at. So in the year 2000, when the patient safety journey started, more or less, then these were some of the states. The domain of safety was very much one of academics and enthusiasts. Nobody else was interested. The 1 in 10 figure had not yet been documented. Incidents were seen as parochial. Nobody looked for the common causes. There was an attitude when things did go wrong and people looked at another institution and said, well, it wouldn't happen here, we're too good for that. And then, as I explained with the Wayne Jowett and many other cases, the families were largely kept in the dark and walls of lawyers were put between them and the hospital. Have things changed? Well, I'd leave you to judge whether the situation of disinterest has, whether we know more about safety, I think we do, whether we see the common connections, I think we are better at that, whether we're better at handling the victims of harm, I think we're a little better at that, and whether we believe that we could, something couldn't happen in our institution, I think if we do, don't go there, don't be treated there, because it suggests a degree of complacency that is also unsafe. The group in Cardiff here are doing a lot of work on the national incident reports reported through the so-called National Reporting and Learning System, and in England and Wales, something like 11 million incidents have been accumulated. A lot of potential to learn from things that go wrong, but we're rather being swamped by the volume and complexity of that information. But here's how it looks, and there's a nice point in here that I think it's very important that we all realize. The majority of incidents do not cause death or severe harm, but there's enough of them that they shouldn't be happening on that scale. But largely, the top of the pyramid is all we ever look at. So in England, the successor people to the National Patient Safety Agency, they analysed the deaths and severe incidents, severe harm. They never look at the rest. So there's, what, 9 million low and no harm incidents made by conscientious NHS staff that nobody ever really looks at. That would be an anathema to any other industry. Why do I say that? Because the modern movement in safety across the world, in other industries, not just healthcare, is the so-called resilient organization. People have moved beyond purely thinking about retrospective learning from things that go wrong, although that's very important, to anticipating the things that go wrong. And there's been a brilliant book written by two academics at Johns Hopkins Hospital, Carl Weick and Kathleen Sutcliffe. And their book is called, I think, Managing the Unexpected. But they go through a lot of industries and they identify the criteria of a high resilience organization or high reliability organization, one that's very resilient. And one of their criteria, I think is brilliant, and let me just tell you about it. One of the features, they say, is that a high reliability organization makes a strong response to a weak signal of failure. Now, I'm enthusiastic about this. You have to forgive my passion, but this is, to me, a brilliant statement because it sums up where you need to be on safety. You've got rid of most of the deaths and severe harm, and you're going back to look at the minor things that might be straws in the wind to safety. Do we do that in healthcare? Not yet. We don't look at any of these. But let me just take one that I took at random and show it to you. This is made an incident report that would be in the bottom of the pyramid because it didn't result in any harm. But it's made by a conscientious frontline nurse, anonymously, obviously. Commenced the night shift, short-staffed. Doctor in charge was a locum, newly qualified and unable to administer IV medications. The registered nurse is an agency nurse. Only saw 2 out of 10 patients. This is the nurse reporting. She only saw 2 out of 10 patients. The department was overfull with many patients on trolleys. The shift was unsafe with reduced numbers of staff who were inexperienced and lacking in skills. Is that a high reliability organization? I don't think so. It looks to me a rather unsafe situation for patients to be going into. And yet, it would be invisible from view unless within the institution, and this is possible, they were pouncing on information like this and immediately reducing the risks. I think it's more likely that it was seen as the cost of doing business. We're busy, you get these things, you get these reports, nobody died, nobody was harmed, file it away. Whereas Weick and Sutcliffe would say, this is a weak, it's not that weak, but it's a weak signal of failure and it needs a strong response. But at the moment we're not doing that. Now here's another one, and this is where I am getting a bit of a geek because this is one that I really like, and I'm only just going to show you this one more. So let's have a little look at, this is another no harm incident. And this is describing a report describing a routine anesthetic procedure. Second general anesthetic case on an afternoon orthopedic list. Fit and well patient, removal of a ganglion, simple procedure. He was given an induction, but then problems developed. The patient couldn't be ventilated. He was turning blue. There was an attempt to do something about that. It didn't work. And the junior anaesthetist called a consultant anaesthetist who realized there was a problem, there was a block somewhere, and the patient was put on a bag and ventilated easily. So no harm, but a nasty near miss where the patient could have suffered from serious harm. What was the cause? Well, there's a second part that tells us exactly, in a succinct way, what went wrong. On inspection of the anesthetic circuit, a disposable cap was discovered blocking the angle piece. It transpired that the offending piece of equipment had been doctored for the purpose of simulation session some weeks previously, and the doctored airway had been resealed and placed in the anesthetic room. So in other words, good practice to simulate emergencies so that young anaesthetists are properly trained, but it had introduced a different risk because the simulated equipment needed for training had been put back into the from the virtual world into the real world and nearly caused somebody's death. Again, one would hope that that had been looked at and acted upon, but it's down at the bottom of the pyramid with the 6 to 9 million other incidents of that kind. This one I'm going to just skip over because I wanted to just make sure I don't run over time at all. It's a detailed piece of research that I'd done. But thinking about systems, it sounds a rather jargonistic word, but essentially it's an interaction between people, the so-called human factors, procedures, machines, and the environment. Think about the rail disaster, think about Wayne Jowett, think about Mr. Murphy and the nasogastric tube, and you see all of these elements coming together. And those are the factors that need to be explored in that sort of situation. We're quite good at identifying harm. We're not that good at learning from error, though we do it a bit. But we're very poor at the moment, and this is across the healthcare system of the world, at getting better. And so there's the emphasis, really, of what's needed. Stronger systems of learning and, very importantly, effective means for reducing risk and improving safety. And this human factors point, this I tore out of a magazine in an airport some years ago. I've forgotten where I got it from, but it seemed to me a very strong illustration. These are all the people involved in a cardiac surgery operation. Now just think about it. You've got to, all of those people have got to know what their role is, know what their colleagues' role is that they're interacting with. They've got to be a team, one team. And that's the scale and the challenge and the complexity of healthcare. It does happen in other industries, but we're much, much less governed by standardized operating procedures and clear specifications of role, because we tend not to be formal about many of the things that other safety critical industries are quite formal about. My WHO work, I've helped to establish the World Alliance for Patient Safety, and in those other countries of the world which are in the lower income countries of the world, safety has a different dimension. Maternal mortality is a very big problem, for example. This is in the public domain. It was the subject of a documentary, and it was about a young teenage girl, Mama Sessi, who was admitted to hospital having gone into labour, driven the 50 miles or so to the district hospital. One baby delivered en route, but it wasn't realised that she had twins. The second baby came and she got into a torrential postpartum hemorrhage. And the nurses were not sure what to do. They called for blood, they called for the doctor. One way or another, the procedure that she needed wasn't carried out and she died. All too common in such situations. But again, you can look at the Swiss cheese, you can look at the things that should protect. You can see that in this situation the staff were not skilled, they didn't have monitoring equipment, the interventions were ill-defined, and there was no simulation training on emergencies. And yet, things like oxytocin and manual compression of the uterus could have saved her life. So even when the high-tech stuff isn't available, then ingenuity to provide safer care can be provided. And in some parts of Africa, safety is difficult because of the lack of this sort of basic infrastructure. But the WHO's program has found ways, even with the limited infrastructure, to try and put in place improvements. But often it does involve things that wouldn't be acceptable in a country like ours, like standard operating procedures, which infringe, in some people's minds, clinical freedom. So over the last decade or so, I think we've got better in healthcare at thinking about systems. We recognize the problems better. We have a greater appreciation of the human factors elements. That's the areas that have been so successfully dealt with in other industries. There have been one or two successful campaigns. You've got the 1,000 Lives here in Wales. Things like that have been the hand hygiene campaigns, and I think simulation in dealing with particularly competence in the skill areas like surgery and gynecology and so forth have helped to improve safety in the operating side of things. But the disappointments have been really that we're not very good at taking the data and finding effective solutions. Safety is still something which appeals to the enthusiast. It isn't everybody's interest, and we need to do that. There have been some great examples around the world of involving patients and families in championing safety, telling their stories, and that isn't perhaps on the scale that it should be. And then the risks of healthcare and the risks of individual areas of healthcare are still not widely appreciated. So I haven't talked too much about airline safety, but if you just summarize the point I made earlier about commercial aviation and its risks, it now is your chances of dying in a plane crash something like 1 in 10 million today if you traveled in North America or Europe. In healthcare, your risk of being killed due to an error in hospital have been assessed as something like 1 in 300. So quite a gap in risk. To some extent understandable, but probably unacceptably high. Some years ago, I used to do a lot of thinking in the bath. I have trouble getting out of the bath now because of stiff knees now that I've retired. But I did think about things, and there was one occasion when I was left alone in the house, and that meant that I could enhance my bath with my wife's Chanel No. 5 bubble bath, which I wasn't otherwise allowed to use. So I was sitting luxuriating in the bubbles, and I thought, well, what if you were in an airport, and on the tarmac the engineers were doing the pre-flight inspection. Let's say they looked in the engine and saw that one of the wires, I imagined it an orange-coloured wire, was dislodged from its mounting. What would happen? Well, it would clearly be repaired, but the chances are there would be a report up the line about this, and they would immediately think, could this problem be systemic? Could it apply to other engines of a similar sort? And there might be a check of all the air engines of that kind in all the Boeings in the world. And I called it the orange wire test, and I did this editorial for The Lancet. But I did ask myself, how long would it be before healthcare would be like that? That something that happened down here in Cardiff and was learned from would save the life of a patient in Newcastle. Well, I think we're quite a long way away from that at the moment, but the orange wire test is something that I think we continue to apply. So finally, I think it was Nigel Crisp who said that we treat 1 million patients in the NHS every 36 hours. So I thought we'd put them in a plane, or a series of planes, landing and taking off. So we've got a series of planes, and so how safe is our air journey? Is it our patients, metaphorically, how safe are they going to be in the healthcare airlines? So what I thought I'd do is I'd take you down with your ticket and your bag to the departure lounge. I'd get you a nice cup of cappuccino to have before you got on. I'd buy it myself. And we'd listen to the announcements. They'd make a pre-boarding announcement for those with special needs, and small children may now board. Then we'd hear people holding gold cards can now come forward, or traveling business class. Then there'd be a special announcement for all passengers boarding the aircraft, just to advise you that your chances of dying in this flight would be 1 in 300. That would be the equivalent figure in healthcare. How many people would get on that plane? Thank you for listening.